This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker for this evening, we'd like to give you an overview of our free program for those attending for the first time. So we'll go over who we are, what is our program, some upcoming events, then introduce our speaker for this evening, Dr. Maitland, and then have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, who's also on the call, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife, Carol, passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their local communities. We've helped to start over 100 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. The store is the only funding for this program, and it usually covers our monthly web fees. Please visit our store and check out the helpful products that we offer. So just a general disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911. Always consult your doctor before making any changes to your treatment.
Our next webinar is on May 3rd. Sarah Williams, PhD, presents Cognitive Behavioral Therapy as a Coping Skill for EDS. Sarah is with the Cincinnati Children's Hospital and is quite knowledgeable about EDS. So join us for that. And to view our upcoming speakers for May and June, see the webinars page on our website for the full schedule. For those attending live, there will be an opportunity for Q&A after the presentation. Add your questions at any time by clicking the Q&A icon at the top of your screen. After typing your question, click the orange button to submit. Our speaker tonight is Dr. Maitland. She is board certified in allergy and clinical immunology and assistant professor at the Icahn School of Medicine at Mount Sinai in the Clinical Immunology Division. She is also the medical director for Comprehensive Allergy and Asthma Care, as well as the new Mast Cell Activation Center of New York. Dr. Maitland earned her doctorates in medicine and philosophy at the University of Pennsylvania School of Medicine and completed her internal medicine residency at Brigham and Women's Hospital in Boston and her clinical immunology training at Mount Sinai Hospital. She's writing a pamphlet titled Mast Cells Gone Wild, a guide for the diagnosis and treatment of mast cell activation disorder. She's been recognized for her clinical excellence at Mount Sinai and is a New York Times super doctor for several years in a row. Dr. Maitland now focuses on the diagnosis and treatment of primary immunodeficiency and hypersensitivity disorders, including the emerging spectrum of mast cell activation disorders. So at this time, I would like to very warm welcome to Dr. Maitland. We appreciate her coming back for a second time to do another webinar for us. And I'm going to go ahead and turn over the microphone to you, Dr. Maitland. We're so pleased to have you.
Good evening. Am I coming in?
Yes, I can hear you.
Perfect. Well, hello, everyone. Ms. Ham and Mr. Furman, thank you again for inviting me back to kind of talk about this emerging relationship between connective tissue disorders and mast cells that are situated in the tissue throughout the body. So I'm going to try to talk about some developments that have been appreciated, and believe it or not, it's slowly eking into the general medical community to try to figure out how we can better diagnose and then offer various treatments to try to keep these, at least keep the mast cell compartment under better control and not contribute to the signs and symptoms associated with this. So I am going to go to the, so, you know, everyone comes to my office and always says, well, I have allergies. And unfortunately, that's a really general subject to me. It basically tells me you're having some type of reactions, and it can affect any part of the body. You can have allergic headaches. You can have allergic arthritis. You can have difficulty breathing. I just had a woman in my office today who I asked, and she had not put on her questionnaire, do you have any difficulties breathing? And she's like, you know, I actually do get a little tired when I go upstairs. And it's amazing how outside of skin reactions and gut reactions, a lot of these this dysregulation of the mast cell compartment really can affect any organ system. And I'm going to talk a little bit about the manifestations of mast cells when they become dysregulated. So I would say in, excuse me, civilized nations, upwards of 40% of the population are affected by some form of an allergic or hypersensitivity disorder. And typically, a lot of providers have a tendency to focus on an antibody called IgE that sits on mast cells. And then when the IgE sees whatever it has learned to recognize, whether it's pollen or penicillin or foods, it cross-links and acts like an on switch. And then the mast cells starts dumping various chemicals, including histamine. In the top left-hand corner, that is an electron micrograph of a mast cell. At the picture below, that is a stain of bone marrow and a stain to identify mast cells in the bone marrow. And then I just briefly referred to the cartoon on the right where it just talks about what mast cells do when they encounter pollen, in this case, and leads to an allergic reaction, which is classically can cause hives or allergic rhinitis for people that have classic springtime allergies. Really, it's important to get those symptoms under control before it starts progressing into other symptoms or asthma as well. So I really put this slide up, and although it does focus on histamine and histamine intolerance, for instance, mast cells have lots of different chemicals, but more importantly, they have receptors that can impact brain function, airway function, blood vessels, the heart, fat cells, nerve fibers, the stomach lining, and depending on which mast cell populations are engaged, you might have symptoms that will flare up, depending on what the triggers can be. And just to point out, I'm just going to highlight a little bit ahead of schedule, but just talking about some of the treatments that we have and why we use different types of histamine blockers. Medications like Benadryl, chlorotrimazole, Zyrtec recognize the first histamine receptor. Medications like Pepcid, Zantac, and Tagamet are also known as famotidine, ranitidine, and cimetidine, recognize the third histamine receptor. And some patients are a little bit taken aback when I prescribe a medication that years ago used to be used for mood disorders. But some of the older medications that are often called antidepressants, like imipramine and amitriptyline and nortriptyline, they actually work on the first, second, and third histamine receptors. So this is another medication intervention that can help get affected patients' symptoms under control. But the takeaway from this is just to let you know that mast cells sit in every organ system, has the capacity to cause problems if they're not tightly regulated in any organ system if they're engaged inappropriately. So this next slide is just showing some of the more common manifestations in individuals that may have mast cell dysregulation. So after the mast cell is engaged, it can release various cytokines that communicate with surrounding tissues, or it can recruit in other cells from the immune system. There's a huge focus on histamine, but interestingly enough, historically speaking, heparin was the first chemical that was identified in mast cells when they were identified many, many years ago. And this is why some individuals might have issues with more bleeding when they have an allergic reaction because too much heparin is being released. They can also release glucotrienes, which is plays a strong role in some individuals with their asthma, and also can also exacerbate itchy skin conditions. And the medications that we use to target leukotrienes include Singulair or Montelukast. There are other chemical messengers called chemokines. Interestingly enough, tumor necrosis factor, and this is why some people might be losing weight or have a higher loss of their metabolism, is because they're releasing tumor necrosis factor. There are various enzymes that get released, and I think many of you are familiar with tryptase, but there are other enzymes, including kinase and carboxypeptidase, that get released. But unfortunately, those tests are not commercially available to try to identify whether or not somebody might be at risk for mast. And I wanted to just highlight serotonin and nerve growth factors. These are direct communication with mast cells. So mast cells are able to impact the vasculature and also able to impact the nerves as well. Anybody who suffers from, for instance, cold-induced hives, or they get high, body heats up too fast, which is called cholinergic urticaria, that is a nerve mast cell connection that's causing that type of reaction. And so this is called a physical trigger that may be contributing to one's symptoms. But you can see that, generally speaking, someone who has a mast cell disorder, you have to have at least two of these type of symptoms occurring. Either you can have rhinitis, which means you're having congestion issues or mucus in the back of your throat. A lot of patients complain about brain fog, memory impairment, word finding, or headache syndromes. Interestingly enough, not everyone who has mast cell activation disorder has anaphylaxis. We still don't know what happens in the general population of patients that have a non-proliferative or non-clonal form of mast cell activation disorder as opposed to mastocytosis. But in the mastocytosis patients, only about 20 to 35% of those patients report ever having an anaphylactic event. You can have hives, flushing, itch, swelling. You can have an irritable bowel syndrome. And anybody who's had the opportunity to visit Dr. Glover down in Florida, or Dr. Hamilton and Dr. Greenberger in Boston, they were able to show that patients that have irritable bowel are actually at risk for having mast cell activation disorder. So this is another manifestation of mast cells that are dysregulated. Interestingly enough, there is a urologist in New York who no longer calls the bladder symptoms interstitial cystitis. He actually calls it hypersensitivity cystitis, and has actually gone about using medications directly into the bladder to try to calm those symptoms down. And lastly, you don't hear this very often, but there are some rheumatologists and orthopedics who will admit that arthritis can have an allergic component as well. So I want to talk a little bit about the life and the role of mast cells in our bodies before they were known as to be major suspects in the allergy epidemic. So mast cells are generally considered like the local peacekeepers. They're born in the bone marrow. You don't normally find mast cells in the blood, only the precursors. And basically what happens is once they get to their target organ, they kind of differentiate and mature to meet the needs of the local environment that they're sent to. So, and these cells are hardwired to recognize a long tried and true dangers to the tissue. So they have receptors that can recognize bacteria and viruses and parasites. They have the ability to recognize damage either from cold or from different waves of sunlight. Interestingly enough, you can sometimes identify someone who has a mast cell activation disorder because they have large local reactions to stinging insects, including mosquitoes. And that's because, again, the mast cell has the ability to, bypass, the use of antibodies and go ahead and recognize these dangers, and depending on what danger they see, they may release certain chemicals in order to try to contain the danger and call in appropriate help. So I kind of liken a mast cell as the local police officer in your neighborhood who strives to serve and protect that particular neighborhood and have acquired skills in order to recognize common dangers in that environment. And mast cell activation disorder basically means that your local peacekeeper went awry one of two ways. Either the mast cells have acquired a mutation where they no longer pay attention to the rules, and that is a rare form of mast cell activation disorder called mastocytosis, and I'll get into more details about that later. But the majority of individuals that have mast cell activation disorder is the mast cells are actually doing their job. They're just getting bad orders from the surrounding environment. And I would have to say, in order to once you figure out whether or not somebody is affected by mast cell activation disorder, the next step is to figure out what are those bad rules or orders that are being sent to the mast cells so that they're misbehaving. So, before we had an allergy epidemic, this is a really interesting article back over 14 years ago where they tried to understand what was contributing to a larger number of hypersensitivity disorders. And as you can see, as major infectious diseases such as tuberculosis and hepatitis and rheumatic fever started to come down, interestingly enough, the immune system no longer preoccupied with these really dangerous infectious syndromes, you start seeing a dramatic rise in hypersensitivity disorders, whether you're talking about inflammatory bowel disease, multiple sclerosis, type 1 diabetes, and allergic disorders, including asthma, food allergy, as well as hives and rhinitis. And so once you started seeing a decrease in the preoccupation of pathogens by mast cells and the immune system, all of a sudden you have a soldier, a police officer that has been recognizing dangers for thousands of years. The environment has completely changed, and now it's as though you have an immune system that is triggered to attack and doesn't have the traditional enemy to go after. So now it starts going after innocent things, including items inside your body, so that's an autoimmune disorder, or things that come from the outside and get into your body, whether you breathe it in, whether it goes through your skin or you ingest it, now starts to come under attack by the immune system. And so we really have seen, I would almost say that the latter half of the century was the age of immune dysregulation, which was associated with major hypersensitivity disorders. And actually this is probably when we really started to see the coming of age of this mast cell activation disorder epidemic. So instead of going after, worms and bacteria and viruses, the mast cells start recognizing innocent things in the environment. So I think the first thing that was really appreciated by the healthcare community was food allergies and anaphylaxis. Now, if you ask most I hate to use the term older because I'm now there, but if you ask some of the older allergists, they hardly saw food allergies when they first came out of training, and now it's routine. You see sensitivities to foods that you can detect using traditional allergy testing, but then there are individuals, especially in the, I would have to say, in the EDS community, where allergy testing will not address why people are sensitive to these foods. It's almost as though you're having non-celiac gluten sensitivity, or you're reacting to milk, but the blood test and the skin test are completely negative. And then you're also starting to see reactions to synthetic materials, airborne chemicals, off-gassing from housing materials, whether it's the floors or the painting on the walls, spraying perfumes. People are having a lot of occupational exposures. I have a patient recently who had to resign from her position just because the environment where she was working in was essentially toxic to her. And so you see the mast cell using its hardware to recognize dangers, now turning its artillery and all those potent chemicals to start targeting innocent, harmless substances. And now the human body that has this sensitization is now constantly under attack from their own immune system. So to get briefly into mast cell activation disorder and the kind of, or mast cell activation syndrome, I kind of break it down to two different forms. You either have too many mast cells, so you have basically a mast cell that's gone rogue and is disobeying all the local rules and going about on its own, and that is what's considered a clonal or proliferative disorder. And I'll show you some examples of that in the next slides. That is uncommon. There are less than 200,000 cases of mastocytosis and what's considered mastocytosis junior, which is monoclonal mast cell activation disorder. The majority of individuals that are affected by mast cell activation syndrome have the normal number of mast cells. So if they undergo a biopsy of the skin or the gut, or if they start looking for, tryptase or histamine, and understand that these are very potent chemicals, so that you don't want them running around too long. But they are being released on a frequent basis, causing symptoms in various organ systems. And it can either be systemic mast cell degranulation, or it can be piecemeal secretion. So you're either under like a blitzkrieg attack, or you're getting these like pot shot attacks from different parts of your body on a frequent basis. So you either have an increased number of mast cells, or you have increased activity of the mast cells that you have. So the criteria that was put forth by some excellent scientific clinicians, including Dr. Theorides and Dr. Aiken and Dr. Valent, basically put forth 4 criteria. So essentially, you need to have recurrent episodic signs and symptoms of mast cell release of factors affecting 2 or more organ systems. And going back to the previous slide where I showed that you can have rhinitis or asthma or gut symptoms, if you have itchy skin and gut problems, that counts. If you have chronic headaches and gut problems, that counts. You need at least 2 organ systems that are impacted by mast cell dysregulation. Then the second thing is, do you respond to medications or interventions that decrease the frequency, the severity of the mediator release and help you get partial or complete resolution of the symptoms that target mast cells? I had one patient who had had issues for years, and she accidentally stumbled into a corner 7-Eleven and got some Benadryl and felt better. And so that counts. If you respond to a classic histamine blocker like Benadryl or Zyrtec that gives you partial relief, that also counts as fulfilling one of the criteria that leads to the diagnosis of mast cell activation syndrome or disorder. Then, after hearing your story and seeing whether you respond to interventions that reduce your frequency of symptoms or intensity of your symptoms, where is your data? You know, show some laboratory data that kind of reinforces it. And this is where a lot of patients hit a speed bump to the diagnosis of Mast Cell Activation Syndrome. Mast Cell Activation Syndrome was only put together as a diagnosis less than 9 or 10 years ago. And since that time, we only have, and I remember showing all those factors that get released when mast cells are activated, we only have the ability to test for 3 factors, and that's histamine, tryptase, and prostaglandins. Dr. Afrin actually uses heparin as well, but that's kind of tricky to measure in the first place. So it doesn't measure kinase. It doesn't measure carboxypeptidase. It's really hard to get a tryptase measured in the emergency department for whatever reasons. And I also have to, and I want to emphasize here that if you have a normal tryptase, it's really, really important to have a lab slip so you can get another tryptase measured if you're having an acute event. Because the diagnosis of mast cell activation disorder per laboratory data is if you have a tryptase base level and then you go up a certain amount. It's kind of like how we measure individuals that are having a heart attack. You take serial measurements to see whether or not what is the actual baseline and what is when somebody's having an exacerbation. So, and then the last part is to try to go after an organ system where you can do a biopsy and do appropriate staining to identify the mast cells. And I have to say, in my experience, as well as what has been reported by other physician scientists, we've yet to see an increased number of mast cells on biopsy. What has been helpful is to see whether or not the mast cells are chronically activated. And reiterating the image of a police officer, you want that police officer, after they've subdued the danger, to put their gun away, put down their taser. But if you have a police officer who keeps their gun out, something's going to happen. So this is the same analogy with looking at the mast cells. You want the pathologist to not only identify the mast cells with the appropriate marker, which mostly is this marker called CD117, but you want to look for activation markers such as CD25, CD2, and CD30. Because if you see a mast cell with those activation markers, that is also diagnostic for mast cell activation syndrome. So after you've done all that, it's really also important to rule out other causes of symptoms that may be mast cell-like. And I'll show you some of the entities that can mimic mast cell activation disorder. So going after the first criteria, I wanted to reiterate that mast cells literally are found in every organ system. And I don't know of a human that does not have a mast cell. So this is a very important cell population for our vitality and our metabolism. And so, again, it's really important that you identify that you have at least 2 or more organ systems that are impacted by mast cell dysregulation. This can include, again, congestion, central nervous system issues such as processing, neurocognitive impairment, headache syndromes. You have asthma-like symptoms. You've actually had episodes of anaphylaxis. You've had itchy rashes or redness or flushing. You have irritable bowel syndromes. You have arthritic symptoms that come and go. I was just speaking with a young lady earlier today who was telling me that she had arthritic symptoms for years and really didn't appreciate it until she restricted her diet, and then all of a sudden the arthritic symptoms went away. Or if you have interstitial cystitis. And I think what a lot of people are running into is an issue with our healthcare system where you really have specialists for each one of those organ systems and nobody's talking to each other. So it's really important to have one person who's going to kind of act as the coordinator of the efforts. So if you're going to a dermatologist and you're going to a gastroenterologist or you're going to a neurologist, there should be somebody who is talking to all these specialists to kind of say, oh, okay, so the MRI was negative and the endoscopy was unremarkable. So, but is it possible that there's one mechanism that's contributing to that? And that's exactly what was discovered by Dr. Hamilton, Dr. Castells, and Dr. Greenberger up in Boston. It was an irritable bowel syndrome clinic where they asked patients that had IBS, do you have symptoms outside of your gastrointestinal tract? And that's how they identified non-clonal mast cell activation disorder in patients that had IBS-like symptoms. So basically, you just need to ask yourself what's going on and see if you have two or more organ systems that are involved. This is a chart showing what can happen during anaphylaxis. And literally, you can see that every single organ system can be impacted by anaphylaxis. And generally speaking, anaphylaxis is kind of like earthquakes. You can have a grade 1 or a grade 6. Grade 6 means your cardiovascular impairment. But I often use the example of my son who has peanut allergies, and he never has skin symptoms. He doesn't have airway compromise. He just has gastrointestinal distress, and his heart starts to race. And there are doctors who have said that he does not have food allergies simply because he doesn't have any skin manifestations. Not all anaphylaxis has skin involvement. Not all anaphylaxis has airway involvement. Or cardiovascular compromise where your heart starts to race, or lightheadedness or a weak pulse. But it's really important if you've had an episode of anaphylaxis or at risk of, or you think you might have had an episode where you've had sudden change in your constitution after an exposure to a chemical or food or very importantly, an insect sting. It's really important that you have epinephrine and Benadryl on you or some type of histamine blocker in order to stabilize your attack until you can get some help. So I am reporting here some of the studies that have been done on individuals that have mastocytosis and also have non-clonal mast cell activation disorder. The study on the right was done up in Brigham in patients that have had IBS-like symptoms. And you can see, depending on which clinic that the research was done, after skin and gut, the number one symptom that people were complaining about was like brain fog and memory impairment and mood disorders. It was quite common. And so, and unfortunately, there's no quick checkoff list to try to understand, you know, what would lend to, there's no quick depression screen or anxiety screen or neurocognitive testing to show that your mast cell dysregulation is lending to your inability to remember what you just read or impacts on your mood or your sleep. But it's really important to try to take a step back and realize that this isn't in your head. It is your immune dysregulation. And when it comes to individuals that have Ehlers-Danlos, it's not uncommon that you also have autonomic dysfunction. So you have a few different things that may be impacting on how your brain functions. And also you can see for these individuals that have mastocytosis, they also have impairment of their bone metabolism. They have intractable peptic ulcer or acid reflux or heartburn. But the big difference between mastocytosis versus non-clonal mast cell activation disorder, meaning you have a mast cell that has a mutation and now you have an increased number of mast cells beyond what's considered normal. These individuals have a tendency to have enlarged livers and spleens. You do not see that in individuals that have non-clonal / non-proliferative mast cell activation disorder. And that's what my experience has been in individuals that have Ehlers-Danlos without other comorbid disorders that can impact on their spleen or liver. So it really is focusing on the skin, your neurocognitive function, your gastrointestinal tract, and your airways, which may give a clue on whether or not you have mast cell activation disorder or not. Again, there are allergic, meaning I can find an antibody called immunoglobulin E or IgE to an item that you feel that you're sensitive to. But I have to tell you, plenty of patients that have Ehlers-Danlos do not have elevated or inappropriate production of IgE to peanuts or eggs or milk or kiwi. There are other substances in those foodstuffs or in household items that have chemicals in it or medications that may kick off the mast cells, and those are considered non-allergic triggers. But I find that once someone has been dealing with mast cell dysregulation for a prolonged period of time, it seems to lower the threshold for non-allergic triggers to cause similar symptoms and signs. This is just showing other receptors, and I really like this picture on the right showing the relationship between mast cells, neurons, collagen, and how you see all those granules in the mast cells, all those little dense circles are stacks of chemicals that mast cells release when they are engaged, whether they engage through the IgE receptor, the immunoglobulin E, whether or not the complement system gets involved. Some individuals will have allergic-like reactions when they get high concentrations of proteins such as gamma globulin infusions. Also, remembering that the mast cells are kind of like your local police officers sitting at the front, situated right below the surface area of your skin, your gut, and your respiratory tract. They're armed with receptors to recognize bacteria, viruses, and parasites, including proteins and substances that are released by poisonous snakes, stinging insects, or toxins. There are also physical stimuli that can cause mast cells to degranulate. I've had the pleasure of having cold-induced hives and swelling for close to 20 years. So there's some individuals that have issues with temperature going from cold to hot, hot to cold. Some people have what's called delayed pressure or immediate pressure, where they're able to write on their skin. That's called dermatographism or dermographism. There are certain chemicals that can cause mast cells to directly degranulate or secrete symptoms. There are chemicals from other immune cells or the surrounding connective tissue or nerves that can also cause mast cells to release their chemicals in order to maintain or restore the environment to a more homeostatic state. This is kind of elaborating the crosstalk between mast cells and nerve fibers. You can either, let me see if I can get the pointer to work. So you can have a direct, the top left, you have a mast cell that's directly engaging the nerve fibers through what we call cognate receptors. You have chemicals that are secreted by the mast cells or by the nerve fibers that will influence the function of the nerves and the mast cells as well. And then you can also have factors that are secreted from afar. And this is why individuals, for instance, that may have cold-induced urticaria are also at risk for cold-induced anaphylaxis. You have degranulation of the mast cells, and they will start secreting factors down to the nerve fibers, and then the nerve fibers may cause a system-wide reaction leading to some type of anaphylactic event. So there's a lot of crosstalk between all the organ systems, which makes sense. These mast cells are embedded in the connective tissue, monitoring the surrounding environment, which includes blood vessels, fibroblasts, fat cells, nerve fibers. All of these organ systems are crosstalking in order to maintain your metabolic state and homeostasis. So moving on to the second criteria is, now that you have these different signs and symptoms, is this mast cell contributing to it? And the best way to sort this out is whether or not you respond to medications that are well known in reducing susceptibility, reducing an allergic reaction or a mast cell reaction. And so there are plenty of over-the-counter remedies, including histamine blockers. You have first-generation antihistamines like chlortrimeton and Benadryl. You have second-generation antihistamine blockers such as Zyrtec and Claritin, loratadine, as well as Allegra, which is fexofenadine. You have Singulair and Montelukast, which is a prescription. You have Cromolyn, some forms that are available over the counter, some that are prescribed. You have Ketotifen, which is available as an eye drop in the States. You have steroids, but steroids are not as specific to mast cells because they can suppress other organ systems as well. You have topical creams that also can impact on mast cell function, including Cromolyn and the use of Ketotifen. There are some herbs that are known to have antihistamine activity as well. Vitamin C. There's a New York Times article back from the 1950s that showed that vitamin C was very effective for keeping quote-unquote allergies under control. I'm wondering what the relationship of vitamin C is to keeping allergies under control, since vitamin C is actually extremely important for connective tissue. So again, I'm wondering whether this is a direct effect or indirect effect with the use of vitamin C and quercetin and other things that are known to stabilize the connective tissue such that the mast cells do not become overactive. This is a cartoon illustrating what happens when mast cells armed with immunoglobulin E recognizing some allergen, which could be either pollen or animal dander or nuts or shellfish. You have this cross reaction, and then instantly you have these granules being released from the mast cell into the surrounding environment. And in those granules, you'll find histamine and tumor necrosis factor and enzymes and heparin, which in the nose and in the airways will cause increased mucus production, cause you to itch, cause you to sneeze, have increased congestion issues. And then within minutes, you start having the second wave of mediators being released, including prostaglandins and leukotrienes. In the airway, this can cause wheezing and bronchoconstriction. And then hours later, and remembering that mast cells are the first responders, they will call in help depending on what they see. And in this case, this is a model for allergic inflammation in the lungs or in the airway. You have the release of chemical factors that will not only recruit in what's called a sharpshooter for killing parasites, which are eosinophils, but will also cause production of more antibody that recognizes the insult that started this reaction in the first place. And you also end up with more mucus production from the production of these cytokines as well. And superimposed on this diagram are some of the agents that are known to impact substances that get released immediately, that are produced within minutes and then within hours. So currently we have a molecule called omalizumab, and the trade name is Xolair, which binds to IgE. And interestingly enough, it's been used for years for allergic asthma, but within the past 2 years, this molecule has actually been shown to be very helpful for chronic urticaria as well. We have histamine blockers, and then I had mentioned earlier there are old-fashioned medications called tricyclic agents, which psychiatrists years ago used to use in much higher concentrations for mood disorders such as anxiety or depression. But interestingly enough, allergy immunology specialists use it for hives, gastroenterologists use it for IBS, and neurologists use it for migraines. And so here's a old medicine that has found a new life in helping individuals that have mast cell activation disorders. You have the use of leukotriene blockers, and there are 3 that are out there. The one that's most well known is Montelukast, but you also have Zofilukast as well as Zyflo and Xyluton. You have good old steroids, whether you use them topically as a cream or as an inhaled medication, or systemic steroids, whether it's an injection, you take it in a pill form, or through intravenous administration. And then you have a very benign medication, if tolerated, are mast cell stabilizers, including catodafin as well as cromolyn. So once again, you have the symptoms, you've had some treatments that have made you better. Okay, so now you need to show the data. And there are lots of different tests that are available. I'm not going to focus too much on that because I really like to get to talking about manifestations of mast cell activation disorders in individuals that have connective tissue disorders, especially Ehlers-Danlos type 3 or hypermobility syndrome. But the ones I'd like to highlight here are it's really important that you either get skin testing or blood testing for allergen-specific tests looking for common airborne and food allergens. It would be important for you, if you're having gastrointestinal symptoms, to potentially undergo an endoscopy or colonoscopy to see whether or not mast cells are overrepresented either in number or activity that may be contributing to your gastrointestinal distresses. There is some genetic testing that's probably more available right now for those that have a clonal disorder. So there is testing for the c-KIT gene to see whether or not that is mutated. And then you have some simple tests such as looking for physical urticarias, looking in the nose to see whether or not there's ongoing rhinitis, doing a spirometry to see whether or not you have undiagnosed lower airway involvement, which is not so uncommon. For individuals that are having interstitial cystitis, you're having symptoms that are worrisome for recurrent urinary tract infections. It might not be recurrent urinary tract infections. It actually might be interstitial cystitis. So sometimes having a urologist involved, potentially biopsying the wall to see whether or not mast cell are chronically activated in the bladder wall may be informative on whether or not you have a mast cell activation disorder, or at least lend laboratory support to the observations regarding your personal history and your response to well-known treatments that calm down mast cells. So this slide is just emphasizing some of the laboratory data that's commercially available right now. Although it's commercially available, you might have to really enlist your provider and the pathologist to get these studies done. But again, looking for a serum tryptase not once, but maybe at least 2 or 3 times. Checking for serum and urine histamine. Checking for urine histamine as well as prostaglandin, including prostaglandin D2 and 11-beta F2 alpha. And then also on biopsies, it's really important not only to count the number of mast cells, but do they look normal? You know, so if they have an elongated shape or they're spindle shaped, that also lends to a chronically activated mast cell as opposed to one that's sitting there waiting to look for danger as well. So you need to ask yourself, are your symptoms due to mast cell activation disorder? Because like I said before, there are other conditions that can mimic your symptoms. And I have to say that as an allergy immunology specialist, I have a tendency to lump in histamine intolerance with mast cell activation disorder simply because mast cells and basophils are the largest repository for histamine in the body. There are some individuals that have had some benefit with the use of diamine oxidase replacement. I haven't had that much success with the patient population, but I think it is an innocent enough intervention to try to see whether you got any benefit. But that being said, if you have some or several of these symptoms that are worrisome, it's really important to make sure that you don't have other conditions. And in this slide, this shows that there are other conditions that can definitely mimic or cause symptoms similar to what you've learned about regarding mast cell activation disorders. So, few or no allergies but still reacting. I have to give credit to one of my patients who said, look, I don't understand. I've had, thousands of dollars of allergy testing, and I'm still reacting even though I've eliminated all foods and what have you. And I think, again, this goes into trying to better understand how mast cells work. And so I kind of borrowed this little sign from the Lego movie talking about good cop versus bad cop. So basically, if you have mast cell activation disorder that's due to a mutation in the mast cell, so you go from a nice resting mast cell, if you go to the lower image on the right-hand side, that is electron micrograph of a resting mast cell where you see all the granules sitting in there. So this is a mast cell that's loaded and waiting to release its chemicals, as opposed to on the right, this is a mast cell that's degranulated. So you can see all those granules that had accumulated below the surface have been released into the surrounding environment. So in mastocytosis, which is one form of mast cell activation disorder, basically you've had a subset of mast cells. You have a bad apple mast cell that's gone awry. That's not what I find to be happening in individuals that have connective tissue disorder. What I find most patients have, especially in the connective tissue, individuals that are impacted by connective tissue disorder, these are mast cells that are good cops. They're just getting bad orders. They're bad laws that are going on. And I think the bad laws happened in a world where we have so dramatically changed our environment. Our bodies have not been able to acclimate to these dramatic changes that have happened in less than 20 or 30 years. So these are some of the questions or chief complaints that patients have come through my office. And again, highlighting that there's at least 2 organ systems that are involved. So whether you're having hives and starting to feel faint, which implies cardiovascular impairment, you get bloated and your joints hurt every time you eat something that has gluten. Again, 2 different organ systems. During ragweed season, not only is this young boy having problems with congestion, but now he can't eat fresh melons without getting gastrointestinal distress. We've had individuals that end up getting who have allergic reactions where they not only get flushed in the face and itchy, but now they have to go to the bathroom, which can cause urgency, either the bowel or the bladder. And then we have individuals, which is probably the most common manifestation I see, is that they start having skin symptoms and airway symptoms as well. Again, you either have a bad apple mast cell that's gone awry, which is uncommon, or you have mast cells in organ systems, or 1 or 2 organ systems, or actually 2 more organ systems, that are causing symptoms. So you can be having flushing, itch, hives, tachycardia, you're feeling lightheaded, or syncope. I actually had one patient who would eat almond Cheerios every morning, and she said she's been eating that for years, but also she feels dizzy toward the late afternoon every day. And she finally took the almonds out of the Cheerios, and turns out she had mast cell activation disorder. You'd have difficulty breathing, whether you're wheezing, coughing, feeling short of breath, having reactive airway symptoms. These are a bunch of symptoms, but just want to let you know, if you have a stinging insect allergy, even though the allergy testing is negative, that's a worrisome for mast cell activation disorder. If you have circulation problems, remember I said that young lady who kept on eating, Honey Nut Cheerios, she was always lightheaded, and essentially she was having like mini anaphylaxis on a regular basis simply because of the food that she was eating. When you find that you're sensitive to certain drug allergies, intolerance to anesthesia, pain medications, especially morphine-like substances, or fluoroquinolones such as levaquin or ciprofloxacin. If you're having like IBS-like symptoms, it's really important to see whether or not you may be having a mast cell activation disorder. Again, make sure that you are responding, having either a partial or a complete response to use of anti-mast cell treatments or stabilizers, and that you have some activation markers to kind of support the symptoms that you're having, and also steer away from other diagnoses that might be contributing to the symptoms. And then this is a classification of mast cell activation disorders that was identified, that was put forth a couple of years ago. So basically you have, primary means that there's something wrong with a group of mast cells, and they just keep growing and growing and growing and not ignoring all the rules. I'm not finding that to be a common phenomenon in mast cell activation disorder, in Ehlers-Danlos or connective tissue disorders. You have secondary mast cell activation disorders. Again, mast cells are doing their job. They're just following bad rules, bad orders. And the most common is what most allergists know about is individuals that have made an antibody, IgE, to things that are completely harmless. This is an antibody that was used to identify parasites, and now it's been co-opted to recognizing peanuts and pollen. We have some individuals that either have a primary immune deficiency or some type of an autoimmune disorder or a cancerous process, and this will cause the mast cells to be overactive. I'm going to focus more on the physical urticarias because I think this kind of gives us an idea of what might be going on in individuals that have connective tissue disorders. And then you actually have individuals that made an antibody against the mast cells, and that's called chronic autoimmune urticaria. And then you have a group of people where we just still don't know why they might be having symptoms, but you try to treat and make them comfortable as much as possible. This again is illustrating the difference between primary mast cell activation disorder as opposed to secondary. So people who have mastocytosis, they have too many mast cells. But the issue with individuals that have connective tissue disorders, I think, is at the other end of this triangle, where the mast cells are getting bad orders from the surrounding environment, and that's causing them to be easily activated and degranulating. So, again, you have this on the left-hand side is individuals that have mast cell activation disorder. That's the proliferative or clonal type. This is one of my patients who has a mastocytoma. So he has a mutation in his mast cells causing the mast cells to accumulate. This is another baby that has mastocytosis. And what's interesting in babies and children that have mastocytosis, the symptoms actually seem to come under control once they become a young adult. So this is definitely the bad cop. You have some bad apple mast cells that are misbehaving. So individuals that have connective tissue disorders, and here's an example of a young lady who was allergy tested, and you can tell by her elbows that she has joint hypermobility syndrome, but more importantly, she has really prominent reactions when I put histamine on her arms, much more prominent than the patient that I tested before who didn't have this joint hypermobility. So there's something going on between the communication between the mast cells that are in the connective tissue of people who have evidence of a connective tissue disorder. I don't know if I can say that a little bit more clearly. Essentially, individuals that have a connective tissue disorder seems to be some type of miscommunication with the mast cells that are embedded in the organs, causing the mast cells to be more easily activated. And so this is, again, good cop just following bad orders. This is to kind of just quickly go over mastocytosis. This is another mastocytoma in a baby that I'm taking care of. And basically, the diagnosis of mastocytosis is a major criteria. Like, we can find a bunch of mast cells somewhere, especially in the bone marrow or the skin or the gut. Or you have minor criteria where you have atypical-looking mast cells. So this mast cell over here is rather round, but this mast cell is elongated or spindle. So this is the difference between kind of like a normal-looking mast cell and a mast cell that's gone awry. That they're chronically expressing activation markers such as CD2 or CD25. That you actually find a mutation specifically in the bone marrow of the c-KIT protein or gene. Or if you have a baseline serum tryptase, and I would have to say serum tryptase is probably one of the more sensitive markers for looking for mastocytosis, but it's not very sensitive for other forms of mast cell activation disorder. Hugh Sampson, who really has contributed a lot to the food allergy world, in clinical research and treatment, years ago said it's amazing that people can have anaphylaxis to foods and you can check a tryptase all day long and it's never elevated. And I have a tendency to kind of remind a lot of my colleagues is, we see food-induced anaphylaxis quite a bit, and you'll never see an elevated tryptase. You may find an elevated histamine level if you can catch it, but tryptase is never elevated. So really relying on tryptase to rule out mast cell activation disorder is faulty. And I think individuals should be given an opportunity to get at least 2 or 3 tryptases over a 6 to 12-month period of time, unless there's some type of acute event where you can capture it, in order to help with the diagnosis of mast cell activation disorder. So talking about secondary mast cell activation disorders, which is where I think connective tissue, individuals that are impacted by a connective tissue disorder comes into place. I already talked about allergic disorders and primary immune deficiencies, but really I'd like to talk about is the communication between fibroblasts and mast cells. So here we're just looking at IgE, and if pollen comes in, the mast cell will degranulate and will release chemicals that impact the surrounding nerve fibers, may call in eosinophils. We'll talk to the surrounding fibroblasts, which will crosstalk with mast cells, and then might call in other lymphocytes to make more IgE. This degranulation leads to throat angioedema, a runny nose, sneezing, hives all over, asthma attacks, allergic arthritis. There's been lots of variations on the theme. Regarding connective tissue disorders, though, I really think this is an issue about whether or not, and I'm going to borrow some comments by a very insightful veterinarian years ago, who commented that he felt that Ehlers-Danlos syndrome was the key to collagen disorders. And I'm going to add that I think Ehlers-Danlos might be the key to mast cell disorders as well. And so he made this comment saying that some things appear to be here on Earth to help us understand how things work and go wrong, like peanut allergy. When we look at EDS, we see that some interesting things like the extremes of what goes wrong when collagen gets screwed up. Have you wondered why some generally rupture their cruciate ligaments during a certain time of their lives about the same time that others are blowing out their discs, developing heart murmurs, and suffering from immune-mediated disorders, and that this first big wave of cancer that they might be experiencing earlier in life? Have you seen patterns that beg answers like the same patients having this happen even the same time of year? Yes, I had seen 3 cruciate ligament injuries come in the same week last month. Coincidence? I don't think so. Why do they rupture those in one leg and then 6 months or a year later, sometimes to the day, they blow out the other? That's the pattern we see in almost all immune-mediated diseases of tissue, whether it be the eyes, the neurological system, and even the kidneys. How about the ones that do it in the earliest in their lives? And this is Dr. Symes, and he calls himself Dr. G. And I just took out the fact that he's actually talking about dogs. But interestingly enough, and this is the upper hand picture is my brother had an old English bulldog and who had developed a mast cell tumor. And interestingly enough, when she was a year old, she blew out both of her cruciate ligaments. She had back problems. She had heart problems. She had a really sensitive stomach, so the dog had a very expensive diet, had motility disorders. And it's these patterns that we see in certain species of dogs. Well, I think there might be a correlation in that we see individuals that have inherited patterns in their connective tissue that may be predisposing them to different issues, whether it's musculoskeletal, cardiovascular system, gastrointestinal system, or mucosal damage that may lead to secondary intolerance to certain foods. And Dr. Symes uses the term leaky gut. But it's interesting to think that if there's something wrong with the connective tissue that now allows the underlying immune system to see what's going on in the gut, you might end up starting to have intolerance to foods, not necessarily allergies, which then keeps on perpetuating that damage. And then you start having issues with micronutrient malabsorption, IBS-like symptoms. So the latter part of the talk, I'm going to essentially focus in on Ehlers-Danlos, and specifically the hypermobility syndrome form in the human population, as opposed to our four-legged friends. This is a picture of a mother and son that I take care of. Interestingly enough, mom is dealing with, she's trying to stave off bilateral knee replacements at 35, and her son has a tendency to have rhinitis, asthma, and gastrointestinal symptoms on a recurrent basis. So I kind of borrowed this figure from Dr. Castori, who is a geneticist, and I think many of you may have access to this article that's online, where he basically talks that individuals that have joint hypermobility, Ehlers-Danlos form, are at risk for all these different syndromes, whether it's chronic pain syndrome, chronic fatigue, exocrine gland dysfunction, so something's going on with your thyroid or your adrenals or your pancreas. You're having cardiovascular dysautonomia, so here we're talking about orthostatic intolerance or POTS. You have pelvic dysfunction, so you're having chronic issues with your pelvis in pain, for instance. You can have a chronic headache syndrome. And Dr. Castori alludes to immune dysregulation, but he doesn't really elaborate on what that might mean. And I think this observation in the veterinary world may translate into individuals that have inherited connective tissue disorders, and that might give us an idea of what's going on with mast cell dysregulation, even though there are few or no allergies detected. So this is just as an immunology specialist talking about genetically inherited connective tissue disorders. I understand the classification has probably changed, but basically you have classic joint hypermobility, vascular, kyphoscoliotic, arthrochalasia, and dermatosparaxis. And interestingly enough, the most common form, which is the hypermobility, they don't know the genetics for this. Although there's been recent implications for a gene called tenascin. Nonetheless, most patients unfortunately don't get diagnosed by Ehlers-Danlos because we don't screen for those disorders. I'm lucky that patients get a breathing test, forget about being bent in certain directions or checking for skin extensibility. It's just we were never taught, and it's slow to kind of creep into the biomedical community. So basically this kind of falls into the hands of rheumatology, orthopedics, and neurosurgery to identify individuals that might be at risk for joint hypermobility. But in order to understand the impact on other organ systems, you really need to have a much broader view. You almost have to be a specialist with a generalist eye. So of the 6 subtypes that I just spoke about regarding Ehlers-Danlos syndrome, joint hypermobility syndrome seems to be the most common. So as an allergy immunology specialist, in addition to doing skin testing and spirometry to assess lung function, I started to learn to bend people in certain ways to see whether or not they're at risk for having benign joint hypermobility syndrome. What has been of interesting news within the past couple of years is there have actually been some publications, and unfortunately they have a tendency to be published in not the general literature. It doesn't have a tendency to be picked up by Reuters or WebMD, but I have to definitely acknowledge the work done by Peter Vadas up in Canada, who put forth this study showing that there seems to be this triad of Mast Cell Activation Syndrome, postural orthostatic tachycardia syndrome, and Ehlers-Danlos. And if you look at the slide next door, really you have all these cells cross-talking. So you have the mast cell, you have nerve fibers, and you also have the collagen. And they're all crosstalking, working as a unit. So what he did basically is he screened patients who were formerly diagnosed with POTS by cardiology via tilt table test. And he found that, and then did a screening for Ehlers-Danlos using the Beighton score. And if they had five joints over 9, and also had diagnostic skin biopsy. And I actually had to speak with one of my dermatology colleagues who said that really the best way to diagnose this is with certain electron microscopy, looking at the collagen fibrils to see whether or not that would be informative. Like I said, there's no genetic test that I'm aware of that can identify joint hypermobility, EDS. And let me just comment that those subtypes is rather fluid. So you can have individuals that have overlapping involvement of other subtypes. Those are kind of artificial dividers. But after identifying the individuals that have POTS and have a connective tissue disorder, they went ahead and did a questionnaire to see whether or not they have symptoms worrisome from mast cell activation disorder. And what he found is out of the 15 participants that had the formal, who were screened, and interestingly enough, all of them were female, 12 of them had the formal diagnosis of POTS, and 9 of them were found to have POTS and EDS. Then, out of the 9 that had POTS and EDS, 2/3 of them had symptoms per questionnaire that were worrisome from mast cell activation syndrome. So I'm looking forward to seeing the follow-up studies from Dr. Vadas and his colleagues to kind of further evaluate what the questionnaire suggested. So a few years ago, I also kind of made an observation where I had patients that were coming in that were concerned about allergic disorders, and again, their allergy testing was completely negative. So what I did was a study where we had 10 patients who were found to have Ehlers-Danlos syndrome, and then we went ahead to see whether or not we can identify mast cell activation disorder. So not only did we do questionnaires, but we also did kind of a chart biopsy to see whether or not we can find the 3 criteria that would lend to support a diagnosis of mast cell activation disorder. So we gave them validated questionnaires for rhinitis, which is basically nasal congestion, postnasal drip, urticaria/hives, and swelling or angioedema, asthma, as well as whether or not they had an episode of anaphylaxis. We looked to see whether or not they had spirometry or peak flow measurements, reviewed all of their labs, and then did an analysis to see whether or not, and we also had confirmation of the Ehlers-Danlos joint hypermobility syndrome either by a geneticist or rheumatologist. And these are the 9 patients where we got all the information together, and you can see there's both male and female, and ages range from 6 to 54. Everyone was Caucasian. Everyone was Caucasian, and several of them had identified a family relative that had similar symptoms as well. Per the geneticist, the physiatrist, or the rheumatologist, 6 adults between the ages of 31 and actually it was 54, 3 children between the ages of 5 and 9, and as you can see, the majority were female patients. And interestingly enough, 78% of them reported symptoms that were worrisome for not well-controlled rhinitis, whether or not that was congestion, postnasal drip, sneezing, runny nose. And all of them reported that they did well either using a histamine blocker, a mast cell stabilizer, which is nasochrome, or a leukotriene modifier. Typically that was montelukast. 100% of them reported that they had something going on with their skin. Primarily hives, but some people had flushing. Some people actually had angioedema. And the highs could be sporadic in the form of delayed pressure urticaria or cold-induced urticaria. They definitely had these skin symptoms very frequently per week, and as you can see, nearly 80% of them responded well to the use of just oral antihistamines to control their skin symptoms. Unfortunately, 7 out of the 9 had reported at least one episode of anaphylaxis, and it was an acute onset of illness. It did require, some of them did require epinephrine use, and they reported either having skin, gastrointestinal issues, cardiovascular, or respiratory compromise. And they responded to the use of histamine blockade, epinephrine, and corticosteroids. And regarding asthma, I have to say as an allergy immunology specialist who used to practice internal medicine, I really didn't learn how to take care of asthma until I became a specialist. That being said, there are a lot of individuals that are running around with lower airway involvement and don't know that they have it until they get screened or tested. It's a very, very, very easy test, and I would encourage anybody who is suspicious of having mast cell activation disorder that you should get a breathing test just to see whether or not your lung function is preserved. That being said, 7 out of the 9 patients in this study had asthma and had response with the use of an inhaled beta agonist such as albuterol or levoalbuterol. Nearly half of them had to go on an inhaled corticosteroid to keep their lower airway under control, and 78% of them were again on a leukotriene modifier. As far as labs, I have to tell you the tryptase was completely useless in this patient population. All of them had undergone allergy testing, and which is typically the case by the time someone is evaluated by myself or anyone else who has interest in understanding mast cell activation disorder. They've either had skin testing or blood testing, which were, essentially negative. The IG levels were measured in a lot of the patients, and all of them had less than 10 kilounits per milliliter, which is essentially saying this is not an IG-mediated disorder. And this is kind of a summary of the study that I had done, which is basically showing that the patients had symptoms that were episodic and reoccurring. They did show improvement with the use of mast cell disorder, with mast cell antagonists, medications that quiet mast cells down. You can see that their tryptase was really unremarkable, their IG was really unremarkable, and most of the patients had other diseases ruled out, including carcinoid or eosinophilic gastrointestinal disorders that would support the diagnosis of mast cell activation syndrome and exclude the other diagnoses that are commonly associated with similar symptoms. So, and this is, I just summed that up. I just wanted to point out, and I just found out that New York State's not the only state that excludes from the use of prostaglandin measurements, and also the difficulty in getting a tryptase. So I would encourage most of you, if you're undergoing an evaluation for mast cell activation syndrome, you really should have a script where you can have that tryptase checked if you're having an acute flare-up, because it has to be measured within 4 to 6 hours of the onset of the exacerbation in order to capture it. New York State does not allow for prostaglandin D2 testing, and unfortunately, I think there's only 2 or 3 labs in the country that really do a good job with the prostaglandin measurements, including Mayo Clinic, and also ARUP and InterScience laboratories. So, this slide is just to kind of emphasize that there's certain medications. If you suspect that you have mast cell activation syndrome, I do encourage you to go to the Mastocytosis site. There are medications that are recommended that you can have for anesthesia and for pain, and then there are medications which are strongly recommended that you not use unless you have a known history of tolerating them. So I really would encourage using that resource, and it might be something that I can also post on the EDS awareness site if John and Dina are amenable to that. And literally, I just have to say, in this study that I had done a few years ago, These patients, in my opinion, had Mast Cell Activation Syndrome. They met 2 out of the 3 criteria, except for having a marker indicating or validating the diagnosis of Mast Cell Activation Syndrome. So this is kind of some of the things that need to be done if you're undergoing Mast Cell Activation disorder assessment. Definitely categorize your symptoms and your signs. Share what medications worked, what medications didn't work. It might be worthwhile getting a biopsy. Typically the skin is helpful, but also endoscopy or colonoscopy can also be very helpful as well. It's important to check liver function tests, check for tryptase, check for histamine, check for prostaglandin levels. And then I would really recommend, again, a serial tryptase and a complete blood cell count with a diff, just because you might be able to catch that tryptase going up high enough to kind of support a Mast Cell Activation disorder. So in my opinion up to this point, I really feel that if you're having symptoms that are worrisome from Mast Cell Activation disorder in the context of a connective tissue disorder, this is coming under a secondary Mast Cell Activation disorder. And I think there's some type of miscommunication that's going on, either directly or indirectly, between the mast cells and the surrounding tissue that have educated the mast cells to meet the needs of that local microenvironment. This is just to, again, show you lots of chemicals mast cells can release and lots of different symptoms that can be caused by mast cell dysregulation, and also lots of different types of triggers. I really want to emphasize allergens, bacteria, cytokines, drugs, medications, molds, and the mycotoxins. These are chemicals that molds and fungi can release. Certain peptides or chemicals that are even found in foods, whether it's oxalates or salicylates, toxins, especially those that are injected by stinging insects as well as mosquitoes, as well as viruses. And you really can have cardiovascular, skin, digestive, musculoskeletal, neurologic, respiratory, and, and the number one complaint after brain fog is just fatigue or general malaise. Okay. I think in regards to future directions, we need your help. This is about educating our colleagues, and the only way we can educate colleagues is to have research that better describes what everyone is experiencing, epidemiological studies, which would then lead to more lab bench studies to kind of support what's going on in individuals that have connective tissue disorders. There is intermittent information everywhere about this cross-communication between the mast cells, the connective tissue, the vasculature, and the nerve fibers. But it's all piecemeal. We really kind of need a coherent effort, and in order to kind of just increase the number of specialists that are involved in the care, it really is efforts such as John and Deanna and EDNF that really have kind of pulled and pushed and encouraged all of us that are trying to meet the needs of the patients that are coming to our doors to kind of provide education and resources that you can take back to your primary care, and maybe by doing that you can pass it forward and help each other. So I'm going to finish off here, but I really do want to thank all the patients that have entrusted me. I'm trying to meet your needs the best I can, and also trying to spread the word and educate colleagues as well. I want to thank EDS Awareness for hosting this talk. Yet again, I really am grateful for this opportunity. And I really want to thank some of my colleagues who've just been very supportive, who just give me a different perspective on how to see what's going on in individuals who can collapse into a little suitcase like my patient here, including Lawrence Afrin, Mariana Castells, Ken Aiken, Dr. Glover, Josh Milner. We're out here, and we're trying to do the best we can in that respect. There's some references just to kind of help with the with some of the things I presented here during this talk. And it's coming, I promise. It should be out within the next couple of weeks. And I've touched upon some of the subjects that are in this book, but I hope that this could be a helpful pamphlet for everyone to kind of help themselves or their loved ones as well. Thank you for your attention. I'm happy to address any.
Wonderful. Thank you so much. I don't know if you have any extra time to look at some of the Q&A. That'd be fabulous. You can let us know on that. We're super excited to have your pamphlet, and if everybody who's curious, I believe that we'll be able to put a link to that. Would that be possible, Dr. Maitland, when that comes out, to link to it from our website?
Certainly, certainly.
Okay, so people can check back for that.
It's going to be in ebook form, so and that'll be easy enough to kind of just download.
Okay, super. Okay. All right. If you do have any time left over, we do have some questions in the Q&A box at the top of the screen.
Perfect. Okay. Let's see.
If you recall, we do recommend that you use the little arrow way down at the bottom of the scroll bar to move through the questions, because otherwise, if you roll the scroll bar, sometimes it goes too fast. So just wanted to mention that up front. Okay.
Let me see.
And thank you to everybody who submitted questions. We'll try to go through as many as we can here.
So, there's a comment about the use of vitamin C, and not only in interstitial cystitis, but this is also gastrointestinal issues as well. There are other forms that may be better tolerated. Unfortunately, vitamin C is also ascorbic acid, and it's not uncommon for me to find individuals that are vitamin C deficient, almost on the level of scurvy, and this probably is also exacerbating the connective tissue disorder. So we really need to kind of find a way to kind of deliver this so that it's better tolerated, whether it's in other foodstuffs other than, citrus, which may be problematic as well. Someone made a comment. Someone actually made a great suggestion regarding Vitamin Shop as a vitamin C powder. I find that the use of vitamin C derived from the camu berry or rose hips seems to be a little bit better tolerated. Someone actually made a comment about mastocytosis, and interestingly enough, the c-KIT gene, D816 is not the only mutation that's been identified in the c-KIT gene. It's kind of like a similar story that we've seen with cystic fibrosis. You have a predominant mutation, but I believe close to 16 mutations have been identified in the c-KIT gene in children that have mastocytosis. And unfortunately, where those mutations are and how that translates into the prognosis of these patients have not been closely correlated. So we still have much more information that needs to be done regarding evaluation of the D816 mutation. Okay. I'm looking at a question from Meredith. Let me see if I can pull that up again. Okay. I think so. Oh, you know what? John, you can help me out here. Am I missing the Q&A box?
Okay, at the top of the screen, the
Got it.
Q&A has a couple bubbles above it. There you go.
Got it. Woo! Okay. Here you go. All right, so the first question is, okay, so the first question is about the chronic autoimmune urticaria. So just like you can develop an antibody against your thyroid, so you have an autoimmune thyroid disorder, you can also develop an antibody against the mast cells, and that leads you to a chronic autoimmune mast cell disorder. If you have an elevated tryptase and an elevated prostaglandin D2, this definitely supports mast cell activation disorder, and you may have an autoimmune component that's contributing to that. So it's a secondary disorder. Treatment basically focuses on the use of mast cell stabilizers, whether it's pitotofen, chromalin, histamine blockade. There's also the use of omalizumab or Xolair has also been used for the autoimmune chronic urticaria mast cell activation disorder. There's a question about foods to avoid. I have to tell you, I've basically been using the list of foods based on classic food allergies, and it's easier to tell you what you can eat as opposed to what you can't eat, and it can be complicated because not everybody has the same sensitivities. So I basically strongly recommend a gluten-free diet. If you can tolerate grains, it's best to go to the paleo grains. Poultry seems to be fairly safe, but it should be fresh. Some people don't tolerate it being reheated. Fruits and vegetables as tolerated. There's some fruits and vegetables some people don't tolerate, and as it goes to show you, we just need a little bit more help with that. I definitely recommend avoidance of nuts unless you tolerate them and don't feel like they're giving you an issue. Typically, I recommend going down to it's almost copying a NAET diet, but it's basically going down to no nuts, no soy, no milk, no cow's milk, no egg, no gluten, no shellfish, no seafood for 2 weeks. See how you do. If you feel you're better, then you can try to start adding questions back. You can start adding foods back in. Do it for a couple of days and see if it increases. There are some nutritionists that are quite knowledgeable, and I will try to find there's two contact information that might be helpful. So there's a question about can there be greater sensitivity, including the risk of anaphylaxis happening as one gets older, and I would have to say yes. The longer the fire is burning, the longer it's going to burn, and it's going to start developing further sensitivities. A lot of this has to do with the environment that you're living in. So I find that some people if they're in urban environments or are environments that have a lot of processed materials. Recently there have been off-gassing of chemicals from engineered materials that have been problematic for people. So this is definitely an environmental situation working on a certain set of genes. In some individuals, yes, Mast Cell Activation Syndrome can be inherited. So is Ehlers-Danlos, and so you still have that crosstalk. It's not uncommon for me to have a parent bring a child in, and as I'm getting the history about the child, the parent starts recalling things that happened to them when they were much younger as well. So it's really important. it's really important to, if you are at risk for having a connective tissue disorder, to see whether or not you have mast cell involvement. At this point, outside of mastocytosis, there have been no genes that have been identified as of yet regarding Mast Cell Activation Syndrome outside of the c-KIT gene. There is some interesting work coming out of Dr. Milner. He's actually looking at families that have connective tissue disorders. I'm not privy to his observations, but he seems to be seeing a pattern in individuals that have certain connective tissue disorders. He's only recruiting patients or families where at least one family member has a connective tissue disorder and has an elevated tryptase. So we should be hearing some interesting information coming out of NIH soon regarding that. Okay, I believe, all right, so someone was asking about if you have a severe mast cell-related symptom, it's often followed by an episode with striking little mast cell activated symptoms. How can that be explained? So mast cells are able to impact by whether you're having secretion or massive mast cell degranulation. And when they degranulate, they release a lot of chemicals, and they essentially have to reload. So you actually have like a holiday from the symptoms after having a bad exacerbation, simply because the mast cells might be reloading up on the chemicals in order to discharge them again. What do mast cells play? What role do mast cells play regarding the central nervous system? There's a lot of crosstalk between the mast cells and the central nervous system and the peripheral nervous system. So we know that mast cells can release a nerve-derived factor. They also release or have a role in serotonin metabolism, and those are two key players with the central nervous system. They have the ability to release histamine, and histamine receptors are found on nervous tissue as well, so that can impact nervous function. There's a lot of crosstalk. I have to say it's a lot of circumstantial evidence up to this point because we really don't have a great model for studying mast cell central nervous system. Only mast cells, like I said, are only found in the tissue. There's no, and only recently has there been a form of mast cell leukemia that's now studied in the lab that's kind of giving us a clue about what's going on. I do believe that there's some interesting information coming out regarding mechanoreceptors and how that they can crosstalk with mast cells. That might explain individuals that have delayed pressure urticaria, dermatographism, cholinergic urticaria, which is also seems to be direct crosstalk between mast cells and nerve fibers as well. Norepinephrine and histamine mast cells, there are erginergic receptors on mast cells. We use a form of epinephrine. You know, epinephrine is used to kind of shut down hypersensitivity reactions. I don't know if I can elaborate more because I'm certainly not a neuroimmunologist, but I can tell you that individuals that if they start going under, actually, if anything, if I would point to anything, I would point to prostaglandins. There's been work that's come out of Brigham where they use aspirin as well as cromolyn in individuals who complain about brain fog. Interestingly enough, if you put them on a decent amount of aspirin or desensitize them to a decent amount of aspirin or get them on cromolyn, it seems to improve their neurocognitive function as well. So it's a question of if you stabilize the mast cells, can you then restore the nerve function back to a less derived state. And I also have to say that, generally speaking, mast cells have a tendency to upregulate at night and early morning simply because they're also impacted by circulating corticosteroids. And if that's the case, you're going to have perturbed sleep, which can also impact on neurocognitive function as well. Okay. So someone asked a question about mother-child. There are different set of, mast cells can release different substances, and to rely on one test to say yay or nay that you have a mast cell activation disorder, unfortunately, it's kind of like diagnosing a heart attack with just one set of enzymes. Sometimes you need to look at different angles, and sometimes you need to kind of go into the tissue. If you're just looking at blood tests, you're going to be limited because you only have, you only have tryptase, histamine, and then also if the lab is able to properly use heparin. I think another place to kind of see whether or not you have a mast cell activation disorder is to kind of evaluate an organ system that may be involved and potentially get a biopsy to look at constitutively activated mast cells. I have to say that when it comes to stress, stress will go after whatever your Achilles heel is. And when you have mast cells going on and off, day after day for years, and I have to tell you, people can have Ehlers-Danlos for years and never be diagnosed, as John was sharing about his wife. You can have mast cell issues or mast cell activation syndrome symptoms and signs and not be aware of it. I had one patient who came to me for gastrointestinal distress, and I must have asked her, 3 different ways on Sunday, do you have any skin symptoms? Are you itching? And she would say, no. And then finally, when we got on a diet and a medical regimen, she's like, you know what? I have been itching. She was so used to it. And Dr. Afrin actually shared a story about a patient who was so used to collapsing, having like mini anaphylactic events on a daily basis for years, never realized that this was her mast cell disorder. So you can acclimate down to having this immune dysregulation and never get diagnosed properly. And again, even after you have the mast cell activation disorder diagnosis, that just tells me your mast cells are overactive. It's not telling me why. So it's really important that once you get the diagnosis, you need to figure out why the mast cell's overactive. Is it in the context of an autoimmune disorder? Is it in the context of a connective tissue disorder? Is it in the context of an infection? There's lots of things that can cause those mast cells to be overactive, and unless you get at why they might be overactive, I think it would be important to help with the control of the mast cells. And at this point, I have to say that there's no cure, but there's definitely ways to get it under control so you can have some more normalcy and better health. And by the way, there's a recent paper that just came out talking about neurocognitive impairment. I think Dr. Theorides, as well as Dr. Nicholas Santoro, just published a paper talking about neurocognitive impairment as well as mood disorders in individuals that are impacted by mast cell activation disorder. So that would be good resources for patients. And I do believe Dr. Theorides actually gave a talk for EDS awareness. So he has done a lot of work with autism and neurocognitive impairment and brain fog. So he probably could speak more to it than I regarding the neurocognitive impact of mast cell dysregulation.
Yes, he did give a presentation for us, and we'll provide that link along with the information that we'll have on your page as well, if they want to refer to that afterwards.
So someone's asking a great question regarding cranial cervical instability and TMJ. Understand that mast cells and many patients have many pain specialists have shown that if you can't get the mast cells under control, you're not going to get the pain under control. And if you don't get the pain under control, you're not going to get the mast cells under control. So they all feed each other. I believe that mast cells can aggravate cranial cervical instability simply because they have the ability to release enzymes that can impact the connective tissue that may be holding the cervical spine better intact. And this kind of goes to, I kind of brought in the veterinary world, but, there have been observations regarding how cruciate ligaments are worse in certain times of the year. Like my brother's dog ruptured one anterior cruciate ligament one spring, and then the following spring ruptured the other. So there's this crosstalk between, again, the connective tissue and the mast cells. Mast cells are supposed to not only be part of defense, they're also supposed to be part of repair. But if you have a under-functioning repair process or an over-functioning or exuberant repair process, that might be a little bit problematic and can lend to exacerbating pain and also exacerbating the ligaments as well. Okay. I can only take a few more questions, so I'm going to just do a comment between the thyroid disorders and chronic urticaria. I really need to, and I've just met a wonderful, wonderful, wonderful endocrinologist who is willing to kind of think outside the box regarding the crosstalk between the thyroid and the mast cell. And I have to tell you, for years, when somebody would present with chronic hives, we'd always look for thyroid disorders, especially Hashimoto's and Graves'. And so there might be some relationship between what the mast cell sees and then what is on the surface area of the thyroid gland that might explain that crosstalk between that exocrine gland and the immune system. When it comes to treatment, it really has to be a specialist who is willing and able to work with you. So that could be an immunologist, an allergist, pain service, rheumatology, gastroenterology. It's all about partnering with a doctor who's willing and able to help. Right now, NIH does the diagnosis, but they don't do treatment. Brigham and Women's is really focused on mastocytosis, and I believe there is close to a 1.5 year wait to get in, and that has to be a physician referral. I would have to say the boards seem to be a wonderful resource for identifying doctors who show interest and are willing to kind of help with the diagnosis. And I'm going to there's some specific questions regarding diagnosis and management, and Adina, I'm not. I actually am seeing new patients, but I just need to partner with a physician who is local, who is willing to kind of work with me. So we are reopening, accepting new patients. It's just that I'm my office is reorganizing. So if you reach out to the office, just have your doctor write a letter to me, and I'll be able to accommodate an appointment. So right now it's just myself and one other healthcare provider, and we're just trying to meet the needs of the patients that are already in the practice. For interstitial cystitis, they're actually using cromolyn and instilling it and doing topical application of cromolyn into the bladder for helping with interstitial cystitis. So it's called intravesicular irrigation. So I only know of a couple of urologists that are doing it. Interestingly enough, antihistamines actually have been used for interstitial cystitis in the past as well. A really interesting question about mitochondrial dysfunction. I think mitochondrial dysfunction might be contributing to increased stress in the local microenvironment, and I think the mast cells are getting recruited in just because there is increased oxidative stress in the local environment. Again, mast cells are not only supposed to be defending, they're also supposed to respond to tissue damage. And if there's tissue damage because of toxic effects or mechanical stress, they will activate and in order to try to coordinate a remodeling and healing response. Hopefully it's an appropriate response, but sometimes that's not the case. I think I don't. So someone was asking about how to partner. Essentially, the way I've been working is whether it's a primary care or a local allergy immunology specialist or gastroenterologist, we all kind of know our roles as, in the medical home. Literally, it's important to have somebody close to you. So if, God forbid, you have to go into the hospital, or just when it comes to renewing medications or adjusting medications, it's important to have somebody close to you who can do that. That's probably why Brigham has resorted to just accepting physician responses, referrals, and I've not gone to that point, but it's important just to identify a primary care or a local specialist who's willing to work with us, and so we can help coordinate the care closer to home, and we can act as a resource for the patient. Okay, I think I'm gonna
call it a night.
Yeah.
Thank you for your endurance. Oh my goodness. I don't know.
I apologize for whatever questions I haven't been able to get to. But.
Oh, no, I understand. I don't know if you realize that your last presentation with us has almost 10,000 replays.
Whoa.
At this point. Yes. So it's been quite popular. So
okay.
I know that everyone in the EDS community is extremely thrilled that you've come back for a second presentation. So thank you very much on their behalf.
No, my pleasure. My pleasure. Best of health. And honestly, if I can't help, if you contact or if you put comments on the website, I should be able to at least direct you to somebody in the area who might be able to help. So.
Wonderful. Well, thank you for your time and your expertise tonight, and we just really appreciate your perseverance in this very challenging area of medicine.
It's been informative, let me tell you. But I do wish you, and again, I thank you and your dad. Really, this has been an honor and a privilege, and appreciate everyone's patience in this process.
Oh, thank you. Wanted to let everybody know that we will be posting that first webinar that we mentioned on the announcement page that you used to log in tonight, as well as links to the Mastocytosis Society for additional information, and links to Dr. Theoharidis, and also we have an upcoming webinar with Dr. Afrin coming up on June 21st. So for all of you that are very entrenched in gathering as much data as you can about mast cell, I think those will be very helpful resources as well. Again, join us in 2 weeks. Then we will be talking about cognitive behavioral therapy as a coping tool for EDS. And again, go to our webinars tab on the toolbar of our home page, and you can find more information about upcoming webinars offered twice per month, and also have access to over 50 webinars from past speakers from the past 2 to 2.5 years now. So thank you so much for joining us tonight, everyone. And again, thank you, Dr. Maitland. And we're going to go ahead and call it an evening. And we look forward to seeing everyone again next time.
Yeah, thanks, Deanna and Dr. Maitland. We really appreciate this presentation. It's very informative. We're looking forward to seeing you in New York at the conference.
Yeah.
And yes, that'd be great. That'd be great. And I want to remind people that these programs are free, but please go out to our store, Body Support Store. You'll find over 250 products that are actually selected by EDSers for EDSers. You'll actually see the EDS shirts for your EDS awareness activities, and there are brochures if you're into EDS awareness communication to the public. So please check out our site, and we're going to call it an evening, and thanks for everyone who joined, and Dr. Maitland, and have a good evening. Good night.
Good night.
Thank you so much. Good night, everyone.
Good night.